Thank you. And I'm just going to briefly apologize. I was supposed to be giving this with Princess Sarah Zaid, but she had to cancel at the last minute due to a personal reason. So I'm going to script this and do my best. Apologies. So you heard a lot yesterday morning about newborn health at the facility level, specifically with regards to resuscitation and CPAP. So I'm going to build on that by talking a bit more about low-cost, life-saving interventions at all levels, particularly community and primary level. I don't imagine anybody in this audience needs an update as to why newborn health is important, but I'm going to give you one anyways. We know that the day of birth is the highest risk of death for women and their babies. Nearly half of all maternal deaths and newborn deaths, and half of the 2.6 million stillbirths that occur every year around the globe occur during labor, delivery, and in the first 24 hours after birth. And as we all know, most of these deaths are preventable. There's been increasing attention on newborn survival and health as nearly half of all under 5 child deaths occur in the neonatal phase. The 2017 figures that were just updated increased that figure to 47%. And there's also new attention on newborn health in humanitarian and fragile settings, as nearly half of all newborn and stillbirths occur around the globe in those settings. So it's a lot of halves. But the takeaway really is that 75% of high newborn mortality countries can be characterized as recently experiencing chronic civil unrest or political instability. Our international standards that define emergency obstetric and newborn care, as well as in every newborn action plan that was endorsed by the 67th World Health Assembly. But access to quality newborn care is still a major gap in humanitarian and fragile settings. A 2012 to 2014 global evaluation that was undertaken by IWAG found that EMOC and ENC were among the most poorly funded and poorly provided components of a humanitarian response. So to increase attention to the mother-newborn dyad, we attempted to undertake a burden estimate of maternal and newborn mortality in humanitarian and fragile settings. And I want to sort of add a caveat here that we literally just finished this week, so the results are a bit more nuanced. But in sum, I want to highlight the point that in looking at data from 49 countries that experienced acute, protracted, or cyclical humanitarian conflict between 2014 and 2019, only 12, or about 24%, met the SDG for NMR of 12 per 1,000 live births. And in 2015, the stillbirth rate across all of those 49 countries ranged from 4 to 43, with an average of 18. And I'm hoping everybody can see the text on this, but in the boxes, it's maternal mortality rate, newborn mortality rate, and then stillbirth rate. So the need is clear, but what to do? We know that available interventions, when scaled up, can improve outcomes for every newborn and for nations. The health of mothers and their babies is so intrinsically linked that the delivery of effective packaged interventions has a triple return on investment, with the potential to avert 71% of newborn deaths, 33% of stillbirths, and 54% of maternal deaths at scale. Newborn care cannot be provided in isolation, and global guidance reflects that. The recently updated MISP, the Minimum Initial Services Package, the Interagency Field Manual on Reproductive Health in Humanitarian Crises, and the Newborn Health in Humanitarian Settings Field Guide all provide specific guidance and emphasize the importance of quality of care on the day of childbirth for mothers and newborns, especially essential newborn care and care for small and sick newborns. We also don't need to overcomplicate. As we heard yesterday, sometimes less is more with these babies. And as just one example, complications due to prematurity are the leading killer of newborns. And we know that babies born less than 28 weeks are likely to require intensive care to survive, but those are 5% of global cases. About 80% of prematurity births can be categorized as moderate to late preterm, and many don't require intensive support to survive. And it's estimated that half of premature babies could be saved globally through the provision of cost-effective care that can be feasibly delivered in low-resource settings. The global agenda is also focusing on where to provide this care. I think everyone in this room is probably familiar with the UNHCR statistic that average a refugee spends 17 years in camps. But that reality, and it's, I think, worth noting that that's 2 years longer than the SDGs. And that reality is not necessarily reflected by where everybody is. Many in the sector are focused on providing care in acute settings rather than protracted. And while acute may be where the money is, that's not necessarily where the need is. As of 2016, the average length of time that ICRC had spent in countries hosting its 10 largest operations was more than 36 years, which is longer than the MDGs and the SDGs combined. So our global frameworks are not necessarily sufficient for us either. And as people require humanitarian assistance for longer periods of time, the role of communities in responding to those health needs is vital. The reality is that around 1/3 of all mothers do not receive skilled care at birth, and almost 3/4 of babies who are born outside of a health facility do not receive an early postnatal care visit. So the need is at home. And not only is the need there, but fortunately, there's promise in home-based approaches. Engagement of communities through respectful partnerships has shown to be effective at increasing uptake of health services, establishing and maintaining trust between communities and the health facility, and identifying context-specific solutions. Home visits and community-based education campaigns were shown to increase facility births among internally displaced women in Darfur. Recent case studies that were just completed in December of last year in Cox's Bazar and Rwanda illustrated the role of communities in increasing facility births and promoting healthy feeding practices. And in South Sudan, when we piloted the Newborn Health and Humanitarian Settings Field Guide, we showed that illiterate and enumerate community health workers improved their knowledge on newborn care practices and danger signs after participating in our 2-day training, with knowledge improving by 40% or more on questions related to temperature, respiration rate, delayed bathing, and key newborn messages. As we all know, threats to safety and security are a challenge in these settings. Safe access to maternal and newborn health services must be prioritized at all costs, and that might include establishing temporary posts as close as possible to the community, deploying community health workers or home visiting staff who can reach women in their households, and ensuring that health workers have the supplies and training they need to detect danger signs, treat life-threatening newborn complications to the greatest extent possible, and then refer to facilities when the security situation allows. So I hope we all agree that newborn care can be provided and that the necessary tools and guidance do exist. But the reality is that it's not happening. And why is that? Various barriers prevent us from meeting these needs. These include siloed approaches to maternal and newborn health services, limited availability of skilled birth attendants, lack of access to essential commodities, particularly those that are sized for smaller preterm newborns, and delayed access to CMONC. In addition, many of us just simply don't have the skills, or if we do, we're too afraid to use them when we come into contact with a baby. A survey that was just released at the Global Health Cluster last week found that 47% of global cluster partners do not have the capacity to deliver essential newborn care interventions. And to address these gaps, there are a couple of essential actions that we can undertake. The first is to integrate and prioritize maternal and newborn health at the onset of the crisis into your assessments and responses to ensure adequate human resources, financial resources, equipment, and other systems issues are addressed. The second is community engagement and interventions that include potentially clean delivery kits and follow-up visits at home. And the third is building health worker capacity for inpatient care and adequate referral. There is a lot of debate around community-level interventions, I'll admit that, and the appropriate engagement of community health workers and how to encourage facility births in a way that reflect and respect the realities on the ground. I've been told numerous times by agencies and communities that they don't want to disseminate clean delivery kits for fear that it will encourage home births. But the reality is that, and we're seeing this more than ever within the Rohingya response, women and newborns need care and counseling provided at home. Whether the barriers are cultural, ethnic, socio, we have to recognize the care-seeking barriers, and that will particularly include P&Z visits that include counseling on kangaroo mother care and identification of danger signs. More emphasis is also needed on strengthening referral networks and building capacity for inpatient care at all levels. recognizing that not every small and sick newborn needs to be referred and then potentially separated from their mother. So basic resuscitation and infection prevention must be emphasized as a part of BMONC, and provider capacity should be strengthened so as to allow for management of appropriate cases at that primary or peripheral level. As mentioned, we know that there's also just challenges stemming from where the global focus is on acute versus protracted settings. The news and attention goes to the next big crisis, Venezuela, Mozambique, and shifts away from Somalia, South Sudan, Syria, Yemen. So to truly meet that burden, agencies and responders do also need to shift their priorities as well to make sure that we're still working in protracted settings and in fragile and host communities. So with this whole grand agenda, what's next? We do have a research agenda, recognizing that our work needs to be evidence-based, and it includes things like referral systems and inpatient care for small and sick newborns, quality of care, use of MPDSR and verbal autopsy tools, and effective and feasible strategies for ensuring safe delivery practices at home when required. The global community is also moving towards a joint agenda. This includes things like standardization of training curriculums and tools that can then be further contextualized by responders and agencies, potentially training deployable responders within the global health cluster that are trained specifically within neonatal care, and expanding terms of references for responders broadly, for pediatricians, for primary and secondary level facilities to include and emphasize newborn care. We're also collaborating more with the development community to place that stronger emphasis on preparedness and resilience, aiming to build capacity of community workers, the health sector, and national policies and guidelines. And this is all being reflected in a, oh, I hit the wrong one. This is all being reflected in a global 5-year strategy that's set to be launched 2 weeks from today. MSF has been really quite critical in helping us pull this together. But it really strongly emphasizes the importance of the continuum of care and specifically the linkage with early childhood development. I'm going to breeze past the rest of this and hope that it's not included in here. So I was going to show a slide. The development community has just recently completed, it'll be out any day now, a report on inpatient care of small and sick newborns. It's long, it's extensive, it's like 150 pages, but there are 3 pages in there on inpatient care for small and sick newborns in humanitarian settings. But as a part of that report, they actually mapped the importance of small and sick newborns across all 17 SDGs. The aim is so that no one person, no one agency, no one nation moving forward can ever say newborn is not a priority for us, because we've now shown that across the entirety of the health system, the entirety of a structure, that in fact newborn care and small and sick newborn care at that is critical. And so we're at a place where the humanitarian community, I think, really needs to do the same.